Good morning, everyone, and welcome to the program today. Thank you all for joining us here at 6:30 in the morning. Look at you all, superstars. So before we get started, I would like to shout out Dr. Rosemary, who won our gift card this morning. Yay! She gave me permission for this shout out, gang. Okay, so here we have our presentation, RSV in Focus, Pharmacists Driving Vaccine Access, Confidence, and Education. So I want to welcome you all to today's presentation. My name is Dr. Jacinda Abdul-Mutakabbir, but I go by Jam, like peanut butter and jam. So feel free to refer to me and call me such. I'm joined with Dr. Richard Dang. Thank you to PeerView for providing this session and for GSK for providing the educational grant for the symposium. If you have not already, please complete the pre-event survey. As a reminder, look out for additional polling throughout the presentation. Please submit your questions and we will answer them during the Q&A. Please try to remember to do that because we do have microphones, but we want for everyone online to also hear your questions, so please make sure to send them through. In-room learners, use your personal device to scan that QR code on the following slides to respond to polls and ask us questions. For our virtual learners, please respond to polls on your screen and enter questions in that chat window. So once again, we do have a gift card opportunity. I told you Dr. Rosemary won our first one, so then you all know that this is indeedingly real, right? There is a gift card at stake here. So instructions for our in-person learners: each action increases your chances of winning. Please complete that pre-event survey, answer your polling questions, submit questions to the faculty, and if this screen appears on your device, see a PeerView team member to claim your prize. Thank you again, PeerView, for providing the gift cards. So you can go ahead and visit us at PeerView per the rest of this link. You can go ahead and scan this QR code, and the slide and practice aids developed by PeerView can be accessed in the activity menu now and then downloaded after the session. If you need more information, feel free to send an email to that email listed right there, and then you can join the conversation. Make sure that you comment on X and let PeerView know how great this presentation was and how excited you were to join us at 6 o'clock this morning. Okay, so our goals for today's presentation. During this presentation, we will learn that recognizing the burden, clinical features, and risk factors for RSV and RSV-related complications in adults is critical for emphasizing the importance of timely prevention. Applying vaccination recommendations and pharmacy-based risk assessments allow us to proactively identify adults who are eligible for RSV vaccination, and implementing team-based strategies can help overcome barriers to RSV vaccination, build vaccine confidence, and improve equitable access for all patients. So I'll go ahead and yield the rest of this time to Dr. Dang.
Thank you, Jam. Hi, everyone. My name is Richard Dang, and I'm an associate professor of clinical pharmacy at the University of Southern California. We're going to start off with this section talking about from pathogenesis to practice, understanding RSV and its burden in at-risk populations. So just to get started, what is RSV? Respiratory syncytial virus. It is a respiratory virus that can cause very non-specific symptoms, things you would expect like maybe cough, runny nose, fever, and things like that. However, in certain populations, it can be a very serious disease. So while RSV can be mild in many healthy adults, it can lead to severe complications like pneumonia, especially in those who may have comorbid conditions like asthma or COPD, or in the two common populations, the really young and the really old. And so the really young, being children below 5, especially infants, are at great risk for severe disease resulting from RSV infection that might result in significant hospitalization or death. And in fact, in infants, it is one of the top causes for hospitalization within that age group. It also really affects the older population, so adults greater than 70 are known to have poor outcomes and more complications as well, with more hospitalizations and deaths occurring from infection. So again, for most people, generally mild respiratory infection, but for the really young and the really old, it can cause really serious problems as a result of that infection progressing over to pneumonia and other issues. So on this graph, we can see kind of the outcomes of hospitalization and severe RSV disease broken down by different age groups. So we did mention that the over 70 are at the greatest risk, but we also do see increased risk relative to healthy adults beginning at age 50. So on this graph here, we're seeing the breakdown of severe RSV disease for 50 to 59-year-olds and greater than 60-year-olds. We see that for the greater than 60-year-olds, there is a relative increase compared to the 50 to 59, which again is higher than those below 50. Now, the other thing that we see on this chart here as well is that there is a distribution of the risk based on race and ethnicity as well. And so we do see that there are populations such as our Black non-Hispanic population and the Mexican American other Hispanic population that are at greater risk for more severe RSV compared to white non-Hispanic populations or Asian non-Hispanic population. So we know that there is some potential factors related to race and ethnicity that are contributing to poor outcomes for those who may become infected with RSV. Now in RSV for older adults, our primary talk today is going to be focused on adults, not pediatrics, and so we're going to be focusing all of our discussion around this particular population. So when we look at RSV in adults greater than 65 years of age, looking at some of the rates for hospitalizations and deaths, we see about 60,000 to 160,000 hospitalizations per year, and 6,000 to 10,000 deaths per year as a result of RSV infection. This is it's a pretty significant numbers that we're looking at. So these are preventable deaths and hospitalizations that we have an intervention for, which is the RSV vaccine. So as we go into the next slide, just remember that we're looking at about 6,000 to 10,000 deaths per year as a result of RSV in older adults. So with that, we have a polling question. According to US data, what is the estimated annual number of deaths associated with RSV among adults aged greater than 65 years? Choice 1, 100 to 500. Choice 2, 1,000 to 2,000. Choice 3, 3,000 to 4,000. Choice 4, 6,000 to 10,000. Choice 5, it's too early, I'm not sure. So we'll give you a few moments to submit your answers. All right, there we go. So we see the majority of our responses coming in at 6,000 to 10,000. Great job. We are paying attention bright and early. All right, let's continue on some data here. So on this graph, we are looking at the monthly rates of RSV-associated hospitalizations, in particular with older adults. And what we're seeing here is kind of the seasonality trends. And so we want to be able to take away from this chart is, yeah, there are peaks and valleys when it comes to when RSV is more predominant in this country. And it follows a respiratory seasonality that we see similar to influenza and COVID. So really in the winter months, from about October to March is when we have our typical RSV season. The season can be unpredictable. It can peak during different months, just like with influenza and others. The peak can vary year to year. And we do know that with RSV, its seasonality has been affected by the incidence of COVID infections as well. We saw that during the pandemic when COVID was more prevalent, RSV was not as prevalent or the season was more delayed. And interestingly, for this particular year, the 25-26 season, we are seeing a delayed start to the RSV season as well. And so while we typically see peaks in October and November, we haven't quite seen that just yet with RSV for this current season. And so in California, where we are located, CDPH, the Department of Public Health, has extended its RSV season recommendations through April, when would normally maybe end in February. The other thing to keep in mind with RSV hospitalizations is that it also is associated with socioeconomic status. And so as we look at this study that was done evaluating patients and their social vulnerability index, or SVI. SVI is essentially a composite score that looks at a variety of different socioeconomic factors like income, their language, their race and ethnicity, their housing types, their transportation availability. So the higher your SVI, the more socioeconomic risk factors you might have. And so what we're looking at here is we can see that those with the highest SVIs are also associated with the highest incidence of hospitalizations. And so we talked about age being a risk factor for that. We talked about race and ethnicity, but also socioeconomic status, where you're living, how much income you might have, what the jobs that you're doing. All those things can increase your risk of RSV hospitalization, which then leads to a lot of gaps in care and individuals who may be under-resourced and not have appropriate access to vaccines or medical care. The other thing we also know that's associated with increased risk of poor outcomes with RSV is where you're living. And because this is a respiratory illness, it should be no surprise that those older adults living in congregate settings are also at greater risk for hospitalization, infections, and deaths. And so what we're looking here at this chart is the excess risk of those RSV infections, hospitalizations, and deaths for older adults who are living in nursing homes. And so there's a pretty significant increase compared to those not living in nursing homes. And then the next slide, we're looking at those adults who are living in assisted living facilities or skilled nursing facilities compared to those who are community dwelling, meaning they're living in their own homes, right? So those who are living in congregate settings, again, nursing homes, assisted living facilities, or skilled nursing facilities, they are at greater risk of RSV infection, hospitalization, and death, and poorer outcomes. The next slide here we're looking at is individuals and their opinions about whether they want to receive vaccines or not. I think we all recognize that we are in turbulent times when it comes to vaccine confidence and acceptance of vaccine recommendations. So what we see here for RSV is both mix of good and bad news. Good news is that we do still see a majority of individuals who either have already received the vaccine, definitely want to receive the vaccine, or probably will receive the vaccine. And those who said that they definitely will not still remains a minority. So that's the good news. The bad news is those who received the vaccine has plateaued over the last year or two. And so those who are getting the vaccines, they've already gotten it. Everybody else is still in that maybe phase, right? And so that represents opportunity for providers like pharmacists to be able to have a really positive intervention by educating their patients and administering the vaccines to those who still need to receive the vaccine. And then the third point in that little kind of star call out is a no now doesn't mean a no forever. And so for those patients who are in the probably will get vaccine, those are patients we probably want to spend our resources and time on because they're open to receiving information, they're open to changing their mind, but it may require multiple encounters. Just like with smoking cessation, just like maybe any other health decision, sometimes people need to be asked and educated multiple times before they change their mind. And so don't be discouraged by a patient who says, no, I don't want to receive the vaccine today, because you're helping move them closer to the finish line, which is to receive the vaccine, right? And so continue to have those conversations and do not be discouraged. And when we look at that data, those who are not planning to receive the vaccine or might be anti-vax still remains a very small population, especially for RSV vaccines. All right, so why is RSV vaccine a public health priority? Well, first of all, if you are sick and infected with RSV, there are no treatments, right, to help you get better. It essentially is just supportive care. And we're hoping that your body will take care of the infection and that you don't progress to severe outcomes or death, right? So we really want to try to avoid infection to avoid that situation. We also, as we discussed, know that older adults are greatly affected by hospitalizations and deaths, especially if they have comorbid conditions, especially the older they get, and especially if they're living in congregate settings. Yeah. We do know that we have an effective preventative strategy, which is the RSV vaccine. So looking at the clinical data and the clinical trials, we see a range of about over 80% across all of our vaccine types for preventing RSV lower respiratory tract infections in older adults. So we have a very effective tool that we have to prevent these infections, which can then prevent hospitalizations and death. And I know we're not talking about pediatrics, but there's also public health benefits to pediatric vaccination and intervention as well. Young infants are at greater risk for hospitalizations and deaths, and we have a tool through maternal vaccination and monoclonal antibodies that can help improve outcomes in the young population as well. All right. So I think this slide kind of just highlights what we saw earlier, is we are stagnating. So RSV vaccine should be a public health priority. There's a very effective tool, but we are stagnating on the percentage of adults who are eligible for the vaccine actually receiving the vaccine, right? So what that tells me is those who really wanted it already got it, and everybody else is still thinking about it, right? So that represents opportunity. All right. We're going to move on to our next section now that we have an understanding of what RSV vaccine is and why it might be important. I think this is the meat of our presentation. So from screening to vaccination, applying recommendations, and identifying at-risk patients. So let's start with a patient case. Let's meet Marlene. She's a 62-year-old patient with COPD. For the pharmacy visit, she's here today to pick up refills for her inhalers. She asked about a TV ad that she saw regarding the RSV vaccine. We have her past medical history, which includes a medical condition for COPD. Her social history is that she is a former smoker. She quit 20 years ago. And her family history is that she has a mother who is aged 82 who lives with her. Her son and her 4-year-old twins live nearby and visit often. And then data from the last primary care visit 2 months ago is her BP was 128/78, which is good. Heart rate 88, pulse ox 97 on room air, and BMI 28. Recent CMP and CBC within normal limits, and her current medications are her inhalers, tiotropium and albuterol multi-dose inhalers. So we'll revisit Marlene as we learn about how to recognize whether she needs the vaccines or not, but I'll start by asking us to recognize her age and her medical conditions. And those are probably the two big things that we want to take a look at for this patient case. So what are some of the current recommendations? I think that's a common question is, I am so confused about what is happening because there's just so many rapid changes that are happening when it comes to immunization recommendations. So a mix of good news and bad news. Bad news is the chaos. Good news is RSV has been relatively unchanged through all the chaos. So the RSV vaccines remain very stable regardless of which group you're looking at. So whether we're taking recommendations from the ACIP or the AFP, the Academy of Family Physicians, or the AMA Medical Association, we see a pretty common set of standardized recommendations for RSV vaccines. So that's the good news. And so who should be recommended to receive the RSV vaccine? We have a few populations to keep in mind. One is going to be pregnant persons of any age at 32 to 36 weeks of gestation from September to January with only the Abrisvio vaccine. That's the only vaccine that's approved for pregnant persons. And so that is one potential population, and that's the maternal vaccination to mom to help protect the newborn so that they're born with antibodies against the virus. Now, the other populations for adults are all adults over the age of 75. Every single adult over the age of 75 is recommended to receive an RSV vaccine. And that's because of the data with that we saw with the increased risk for hospitalizations and death within that population. Additionally, adults who are aged 50 to 74 who are at increased risk for severe RSV should also receive an RSV vaccine. And we will define what those increased risk factors are, but those are essentially comorbid conditions, right? So as we look at RSV vaccines for adults, we have pregnant persons, and then adults over 50 who may have a risk factor, and all adults over 75, right? So when we think about the age cutoff, we're gonna think 50 or 75. Now, those are the current recommendations, and that's been pretty stable for the last year, year and a half or so. But 2 to 3 years ago, you might remember a different set of recommendations that was for 60 years and older through shared clinical decision making, right? So if you're thinking RSV 60 cutoff, that is the older recommendations. The updated is that 50 age cutoff, okay? The other thing to keep in mind, and we'll talk more about this in the next few slides, is RSV vaccine is not an annual vaccine. It is currently a one-and-done vaccine for now, right? So we do not need to revaccinate patients who've already received a prior RSV vaccine. All right, this slide summarizes those severe medical risk factors like comorbid conditions that increase the risk for severe RSV in those adult patients who are aged 50 to 74. Remember, all patients over 75 should receive it. Those 50 to 74 if they have risk factors, kind of mirroring our recommendations for pneumococcal vaccines, right? So let's take a look at some of the key ones that are on here. There's a long list of different items. We have chronic lung disease, so individuals with asthma, COPD, or other lung disease. We have diabetes mellitus with end-stage organ damage, and I do want to spend some time defining this. This is type 2 diabetes, and specifically with end organ damage. So not just all patients with type 2 diabetes, it's those who have maybe diabetic nephropathy or retinopathy, like more severe disease of type 2 diabetes. Additionally, those who are defined as having elevated BMI greater than 40 with severe obesity, those with chronic cardiovascular disease like heart failure, CAD, etc. However, that does exclude hypertension. And so it's worth pointing that out as well, because while cardiovascular disease is a risk factor, isolated hypertension alone is not an elevated risk factor for RSV outcomes. Some of the other items on here include immunocompromised patients, whether through medical condition or drug use, patients with advanced CKD, either end-stage renal disease or stage 4 to 5, or if they're on hemodialysis, patients who have various neurological or neuromuscular conditions, patients with liver disorders, patients with hematologic disorders, patients who are considered frail. That's a pretty subjective definition, but if they are frail, they are also at higher risk. Patients who reside in a nursing home or long-term care facility based on the data that we saw earlier, that should make sense. And then the last overarching risk factor, if your healthcare provider determines that you are at elevated risk or you have an elevated risk factor. So there are some flexibilities for provider discretion based on that last bullet point. But as pharmacists who maybe are working in a hospital setting and care community, some of the more common ones that you'll see will be the lung disease, will be the type 2 diabetes with end organ damage, and the cardiovascular disease excluding hypertension, right? All right, so with that, we have a polling question. Which of the following individuals is a candidate for RSV vaccination according to current ACIP, AAFP, and AMA adult immunization guidelines? Number 1, a 30-year-old with bladder cancer undergoing chemotherapy and radiation. Number 2, a 45-year-old with severe obesity, BMI greater than 40, and type 2 diabetes. Number 3, a 50-year-old with stage 4 chronic kidney disease and type 1 diabetes. Number 4, a 65-year-old with hypertension and major depressive disorder. Number 5, it's still too early, I'm not sure. All right, so we see the majority of responses coming in for 50-year-old with stage 4 chronic disease with type 1 diabetes. Very good. There's kind of two factors that stand out with that patient case. Remember the age. So that does meet the age requirement of 50 and older. This patient is between age 50 to 74, so we're looking for a severe risk factor. In this case, the severe factor is stage 4 chronic kidney disease. So remember, it was stage 4 or 5, which is a risk factor for this vaccine. So good job, everyone, for answering that correctly. All right, here we talk about how you can optimize vaccine uptake. So remember, we talked about there being a huge opportunity. We're really stagnating on patient uptake, but there's a lot of patients who we know are eligible. So what can we do as pharmacists to help us increase uptake? One is making sure our systems and our personnel are updated on the age cutoff. It's no longer 60, it is 50 and above, right? And so one way we can help increase uptake is running reports. If you have a pharmacy software or an EMR, you can run a report of all your patients who are 50, and those are potential individuals who can be targeted for education and potential administration of the vaccine. In addition to that, if your pharmacy software or EMR allows you to run additional reports based on health conditions or ICD codes or diagnoses, that can help you further refine your reports, right? You can run a report of patients over 50 who maybe have asthma or COPD, or maybe who have type 2 diabetes with an organ damage, or who have cardiovascular disease. If you can't run it based on a health condition, maybe you can run it based off of medications, right? So if you're in a community pharmacy, patients who are picking up inhalers, patients who are picking up maybe statin medications with anticoagulants to help identify those different conditions, right? That's one way to help identify patients who may benefit from targeted outreach and targeted education. And then as patients are coming in for their annual respiratory vaccines like influenza and COVID, take advantage of that opportunity to discuss with them the RSV vaccine. While RSV vaccine is not an annual vaccine, patients who are seeking an influenza and COVID vaccine are already those who are open to vaccination, right? They're less likely to fight you on it because they're coming by their own volition to ask for a vaccine. They're interested in protecting their health. They understand some risk. And so opening the conversation to, have you already heard about the RSV vaccine? Have you received it before? Did you know that this is also a risk in the winter months that we can protect you against, right? So that would be a great opportunity. The other item is that pharmacists can contribute to recommending and initiating and administering vaccines based on the clinical assessment, even without medical documentation. In many states, in all states, pharmacists can engage in vaccine activities, and the CDC and other organizations have recognized pharmacists as being able to contribute to clinical decision-making when it comes to vaccine recommendations, right? So you can play a role here. And you don't necessarily need access to medical charts or medical records because patient attestation of their risk factors is sufficient for many of our vaccine recommendations, right? And so through a screening, through patient interview, you can identify patients who might benefit from this intervention. All right, so let's go back to Marlene. She's our 62-year-old patient with COPD. She came to the pharmacy for a refill. What risk factors does Marlene have for RSV? And again, I'm hoping you're looking at two things that stand out: age and medical conditions. She's age 62, so that puts her in the 50 to 74 bucket. And so with that, we're looking for a comorbid condition. And in this case, it's COPD. A respiratory condition places her at risk. And so ultimately, is she a candidate for vaccination? The answer would be yes. She should be recommended to receive the vaccine to be protected. Let's meet a new patient, Bill. He is an 82-year-old community-dwelling adult. He's here for his annual flu vaccine, and you discussed the option of an RSV vaccine with him because he came in for the flu vaccine. Past medical history for hypertension, dyslipidemia. He's a non-smoker, denies alcohol use, and he enjoys playing board games with his grandchildren. He does live independently in an over 55 community, but he is in his own home or apartment. Data from the last PCP visit: he has normal blood pressure, heart rate, pulse ox, BMI of 25, and his other labs have been normal. He's on lisinopril, hydrochlorothiazide, amlodipine, rosuvastatin, and fish oil. So as we discuss this, we're going to look at age, which really is the main thing, but there may be other risk factors that will push us to recommend the vaccine even more. All right, so what vaccine products do we have available on the market? There are now 3 RSV vaccines that are available. We have one brand name RSV. We have another one brand name Abrysvio, and then our third one is brand name mRESVIA. RSV and Abrysvio are recombinant vaccines for RSV, while mRESVIA is our mRNA vaccine, and that is one of the newer ones that have been recently approved and is on the market. RSV is our adjuvanted RSV vaccine, while the others are not adjuvanted. Abrysvio is the only one approved for pregnant persons, and that's a big key distinguishing factor as well. The other new big update is that as of this month, all 3 vaccines are FDA approved for use in 18 years and older. So there is an FDA-approved indication for 18 years and older who are at increased risk for severe RSV. But you might say, but Richard, you just told me it was 50 years and above. I did. And so it is FDA approved for 18 years and older, but currently based on data, ACIP, AAFP, and other associations are currently only recommending it for 50 years and above. Now, what that means is that in the future, as more data comes in, that if the evidence supports the use in a younger population, that the ACIP and other groups can make those recommendations, right? So this sets the foundation and groundwork for that, to be able to decide on that. Or if providers maybe want to use it, quote unquote, off-label, off-recommendation from ACIP, they can consider that as well. But that is a difference between the FDA and kind of CDC recommendations, okay? All right, so we have clinical data, clinical trial data, and as vaccines come onto market, these are still relatively new vaccines from the last 2 to 3 years. Now we're getting real-world data and real-world effectiveness data about how well the vaccine is working. And so based on some of those real-world observational trials, we see that across the board, across the different age groups, across the different risk factors, we see pretty consistently that there is good efficacy looking at real-world effectiveness. We're seeing rates of 60, 70, 80% prevention of infection, hospitalization, and deaths across those different outcomes. And so what that is telling us is that this is indeed a very valuable intervention, and what we saw in the clinical trials is reaffirmed in our real-world observational data. The other thing that we're seeing is we're seeing sustained protection as well. And that's why this is currently not an annual vaccine, because we do currently have published data across 2 RSV seasons, and the manufacturers are continuing to observe for 3rd and future seasons as well. And what we're seeing is that there is a sustained protection across seasons, and there's currently no need to revaccinate patients who have previously received an RSV vaccine. As far as safety, the vaccines are a safe intervention. The main side effects that we see are the same with many other ones, local site reactions, et cetera. But there is one worth discussing, which is the cases of Guillain-Barré syndrome, or GBS. Both in the clinical data and post-marketing observation, there were some small safety signals for an elevated risk of GBS in older adult populations. And specifically looking at RSV, there were 7 excess cases per 100 million doses, and for Abrisvio, 9 excess cases per 1 million doses. And RSV is newer, and there weren't any cases of GBS in the clinical trials. So with that said, we do recognize that there is a potential increased risk of GBS, a little bit more than the background rate for older adults. So we recognize that safety signal. And so what that means for us is that we do counsel our patients on that particular risk. But what we also know is that compared to the risk of RSV, the risk of GBS is much lower. And so the benefits still greatly outweigh the risk associated with this vaccine. We know that per million doses, again, there might be 7 to 9 excess cases of GBS, but per million doses administered of RSV vaccine, we can save thousands of hospitalizations and hundreds of deaths. And so from a public health standpoint, there is great benefit to continue to recommend this. And so really it's just more of a conversation with your patient and educating them about what the risk might be. The CDC ACIP committee came to that conclusion where the risk for GBS is incredibly rare. It's still really small numbers, but it is worth discussing, and the benefit is still outweighing the risk for this particular population. All right, so practical considerations when discussing RSV vaccine and adverse effects. Tell patients about the most frequently reported side effects, which is the local site reactions. Talk to them about the risk of GBS, but frame it with that it's a really rare side effect, and the benefits of protection greatly outweigh those risks. And then educate them about our monitoring systems with VAERS and vSafe. Our monitoring systems worked. That's how we picked up the safety signal for those GBS cases, to know that that is something we should be observing and discussing. Practical considerations, timing and number of doses. So as we already mentioned, it is not an annual vaccine. You do not need to revaccinate. Patients who've already received it before in the past continue to have protection. The other one is timing. When should you get the RSV vaccine? RSV vaccine will have the most benefit if given late summer to early fall, because by timing it during those months, we can have protection before RSV season starts in the winter season and ensure that they are having the highest level of protection during the peaks of the first RSV season. However, this is not a seasonal recommendation like with influenza. So we can administer RSV vaccines year-round if the patient is asking for it. So you do have to kind of use your judgment. If the patient's coming to you in March and February or April, can I give the vaccine? Yes. Maybe is it better to wait till summer and fall? Sure. But will the patient come back? Are they likely to return? If they're a frequent customer of yours, then great. Maybe let's wait and educate them to do it in the summer. But if you've never seen them before and they seem hesitant, take advantage of the opportunity and give it to them now. So it can be administered year-round. Okay. The other consideration is co-administration. This is a common topic of consideration as well, especially as patients are coming in for influenza, COVID-19 vaccine, and in this age population, they might be looking for a shingles vaccine, they might be looking for a pneumococcal vaccine. There's a whole host of vaccines they may be eligible for. Can you co-administer RSV vaccine with others? Short answer is yes. You can co-administer. There is data to indicate that there's good safety profile, and it is something that the CDC does continue to recommend as appropriate. And I do recommend that as well, because you want to take advantage of your patient's interest and give them all the vaccines that they need at this time. All right, next poll question. Your patient asks you, is it safe for them to receive the RSV vaccine the same day that they receive their herpes zoster or shingles vaccine? How do you respond? 1, yes, but only if the vaccines are administered in separate arms. 2, yes, both can be administered in the same arm if the person chooses. 3, no, the RSV vaccine can only be given at the same time as other respiratory virus vaccines like influenza and COVID-19. 4, no, the RSV vaccine must be given 4 weeks before or 4 weeks after all other vaccines. 5, I'm not sure. All right, good job. Yes, both can be administered in the same arm if the person chooses. Yep, you can administer 2 vaccine intramuscular injections into 1 deltoid if you want. If your patient wants to separate it, they can do that too. And I know there's provided preference. I personally prefer doing the same arm. I talk to the patient and say, I'd rather get side effects in one arm than both arms, but it's up to you. All right, let's move on. Back to Bill. He's our 82-year-old community dwelling adult. So first off, he is greater than 75 years, right? So we should recognize and say he for sure should get the RSV vaccines. No question about it. But what are some other factors that might make us even more inclined to strongly recommend this or consider other options? 1, he has a fever today and reports having chills the night before. Should you give Bill the RSV vaccine? General answer is if they have mild illness, they can still receive any vaccination. So if they have a cold, a light fever, and mild illness, I've always been taught by my mentors as if they can ambulate, if they can walk and talk and come to your pharmacy and ask for a vaccine, they can receive it, right? But if they're bedbound, if he still has chills today, that might not be mild, that might be moderate. In that case, we'll wait. But if his chills are done and he's able to walk and talk and come into your pharmacy, he's good to receive the vaccine. Next, he's starting chemo or radiation or other immunosuppressive therapy soon. Well, remember, immunosuppression is an indication to receive it, so he should absolutely get the RSV vaccine. And if he's starting chemo soon, we want to think about when he's starting it. Preferably, we would do the vaccine 2 weeks before he initiates therapy, because we know that once he starts immunosuppressive therapy, his immune response may not be as high, right? So we preferably would do it 2 weeks before initiation of that therapy. And then 3, he got the RSV vaccine last year. Does he need it today? No, he does not, right? Good job. All right, so with that, ask and earn questions. As a reminder, get your gift cards and participate. And I'm passing over to Jam.
Thank you so much, Dr. Dang. Beautiful overview. So what I'm going to do is really kind of teach you all or showcase application of what it is that Dr. Dang went over in the previous two sections. So overcoming barriers to vaccination, building vaccine confidence, and ensuring access. So we're going to introduce our last patient here. We have Sophia, a 73-year-old Ukrainian-speaking woman, comes into the pharmacy. Sophia comes, it's her first time to have her prescriptions filled. We engaged with an interpreter, and during the conversation, learned that Sophia is unaware of the RSV vaccine. So we note her medical history here, and then our current medications. So when we think about those individuals that come into the pharmacy, as Dr. Dang discussed, we have to think about what will be those barriers of those patients that we see, and what would be those barriers to them going ahead and receiving that vaccine. Well, the lack of awareness of both the danger of RSV infection in older adults and the availability of the RSV vaccine. So I actually do an intervention where I provide education, but associated with that education is collecting data on just the identification of risk and so on that my community members have done. And what I found is that most people, one, don't really know those risk factors associated with respiratory infections. So when you inform them, that can change the conversation. And then also the fact that the RSV vaccine exists. While Dr. Dang did disclose, right, this is a newer vaccine. It's been around, though, since like the end of 2022. So we've had some time with the vaccine. There are so many folks, especially those at highest risk, that have no idea that the vaccine is indeedly here. Lack of vaccine confidence. Well, being unaware of those risk factors, right, and then being unaware of that vaccine can really mediate that lack of vaccine confidence for an RSV vaccine. You can't be confident in things you don't know exist, right? Vaccine fatigue. There are so many vaccines that are available, especially if you're someone that maybe has never received adult vaccines before. You now have a whole smorgasbord of vaccines that you are not eligible for and need to consider getting. So it may be just that inundation with information or the fact that you do have to navigate that. And then cost. How many individuals have to interact with their patients and they have no idea that Medicare Part D exists, that vaccines are available through Part B and Part D for certain patient population groups? That is so frequent. And then it can just be that fear that there is a cost associated with it, right? So that may even keep people from asking about the vaccine because it's like, well, if I do find out it costs money, I know I can't afford it, so why even ask? And then also that vaccine availability at their preferred location. So being able to go where it is that your pharmacy is and that vaccine being available there. But then COVID, right, made everyone kind of manufacturers of preference. So now they say, well, I want the Pfizer vaccine, or I want the Moderna vaccine, or I want the GSK vaccine, right? So we went from just having the staple vaccine to the manufacturers that are now providing those vaccines. So if folks come in and maybe you don't have that vaccine at your particular store, that may mediate their decision to go ahead and receive it. And then providers and health systems, we also have barriers there. So it may also be that lack of insurance reimbursement on the provider end, maybe not knowing, how it is that the vaccines can be paid for, especially with fluctuations in information that we have. Lack of knowledge in light of updated ACIP recommendations. I cannot tell you the number of healthcare providers, pharmacists, physicians, nurse practitioners alike, where I have to say, the recommendations have changed, and it's no longer 60 with the comorbid conditions. It's now lowered at 50 with comorbid conditions. Now that's a whole patient group that we've missed, right, in making that recommendation. Vaccine fatigue. How often is it that Dr. Dang talked about co-administration. So now we're like, we got to give every single vaccine you're eligible here, right now. And it's so much involved with that. You have to make sure you're giving the right vaccine to the right person, that you don't mix anything up. That can be fatigue associated with that, counseling with the vaccines. And then that vaccine stock at the pharmacy or the clinic. Do we have the vaccines available here? Can we actually provide them should someone come in and ask? And with the changes in ACIP, the changes in recommendations, we did notice, right, lags in that vaccine season last year. So now we also have that we have to consider. So the impact of pharmacists and pharmacy personnel, we get the job done. So when you look here, you'll see these numbers, and these numbers indicate the vaccines that are administered by pharmacists. So more than 50% of the adult vaccines that are given by pharmacists. We don't have RSV vaccines yet because, like Dr. Dang said, this is a newer vaccine, but from what we can see from the adult vaccinations here, they are more than likely mostly given by pharmacists, right? So we can play that vital role role in increasing RSV vaccine uptake by providing that convenient access and that expert guidance, that strong recommendation to receive the RSV vaccine. So I have mostly individuals 50 plus in my community that I go and educate. And can I tell you, more than 60% of them said that they had never been told about the RSV vaccine, had never been recommended that vaccine. And they actually told me that they felt betrayed because they interact with healthcare providers frequently and they had not been given that information. So we as pharmacists can really fill that gap and provide that information there. We can ensure accessibility and availability so pharmacies are easily reachable. Hopefully we are consistently stocked with these RSV vaccines. Follow through can be a challenge. So our patients may express that intent to get vaccinated at a pharmacy, but ultimately may choose not to. But as Dr. Dang said, a no once does not mean a no forever. I have had folks come to educations that I do. I've been doing it for the last 4 years now. I'll have people come every single year, and on year 3, they say, okay, it's time for me to get that vaccine. So, I mean, what can you say? But a no, you didn't mean no forever. And then improve communication strategies between providers and pharmacies are needed to ensure that patients do follow up with their vaccine plan. So can we put things into play? I have some of my students here from UCSD in the audience. Can we put our students to work, our interns to work? Can we give them tasks? We can delegate, have them call the patients, right, and assist with follow through. We can do that. So what can we do to proactively approach optimizing RSV vaccine uptake in adults? We can educate and we can encourage. So educate means we can offer disease-related information, so those risk factors that we talked about. We can talk about what RSV is. I think Dr. Dang brought up a really good point. Should you be infected with RSV, we, do a dance around the bedroom, right, around the patient's bed, and we pray that they get better, but we really give that supportive care, and that's all that we can do. That can be a motivating factor for someone to choose vaccines when they know that we're working with, essentially high-grade salt water and a dance and a prayer. So we can educate about that disease, we can educate about those risk factors, and then we can talk about the RSV vaccines, their effectiveness and their safety. And I think a really great point Dr. Dang brought up is that sustained effectiveness from season to season. That can be a really big motivator. We can encourage individuals to receive that vaccine. We can provide a strong recommendation. Hey, you are here today. Get that RSV vaccine. I believe in it, and I think you should too. We can determine whether co-administration is possible. In my education sessions, I always have a segment where I talk about co-administration because I want to make sure folks get all the education they can. But if you leave here with nothing, leave here with knowing that you can get more than one vaccine in one setting. So we really have to maximize that vaccine opportunity. And it also decreases healthcare utilization costs. So that's also a good thing for us. And we can offer incentives for being up to date with vaccines. I myself don't offer them, but however, that can be a motivating factor for individuals getting vaccines if they know that they come to the pharmacy, even so much as a nice little vaccine punch card. That's motivating for folks to be able to have, something we can think about. So educating older adults about RSV vaccines, our 4 main talking points to consider: RSV complications. Older adults are at increased risk for RSV-related complications. That's a point that I really drive home, and what those complications can look like and how sustained they can be. There is no RSV treatment. So when I gave my education sessions, I went through a whole diatribe, a whole conversation about RSV, what it is. And one of the members stopped me and she said, wait a minute. You talked about treatments that you all have for flu, and you talked about treatments that you all have for COVID-19, but I didn't hear you mention one for RSV. And I said, oh, because we don't have one. And she said, that right there is what got me. So that no RSV treatment can be a really big factor that can move the needle with individuals, literally. And so vaccine availability. So RSV vaccines are recommended for those individuals older than 75 or equal to 75, and those 50 to 74 with risk factors, such as cardiopulmonary comorbid conditions and immunocompromising conditions. So we want to make sure we drive home that point. This has expanded. So like I said, there will be a lot of healthcare providers that you all can now give peer-to-peer education. Hey, the recommendations have changed. Do not miss this age group. And then eligibility. Individuals should consult their care team to determine their vaccine eligibility. So when we are educating, when we are bringing forward those reasons to get vaccinated, we really want to talk about the risk to benefits. So that benefit there, vaccines reduce the hospitalization across the 3 vaccines, cumulatively about 75%. The vaccines have been linked to GBS. However, that link is quite small. So that being 10 extra cases per 1 million older adults vaccinated. When I do talk about the RSV vaccines, I do bring this point up. I think that it is really, on us to be completely honest about what the patient faces when they get that vaccine, but that honesty can really go a long way in that sustained decision to continue receiving adult vaccines. But we want to drive home that point. The benefits of being vaccinated far outweigh those risks of receiving that vaccine. So vaccine hesitancy is not unique to RSV vaccines, and we as pharmacists are well equipped to mitigate it. So we can think about frameworks. The CDC has a phenomenal framework. It's called the SHARE framework to assist in encouraging RSV vaccine uptake. So first we start with that S of the SHARE framework, seek. We can initiate conversation and acknowledge the patient's role. So I think that Dr. Dang talked about how you can look at the medication profile when you see those medications. So for asthma and so on and so forth, that person picking up the statin with maybe that blood thinner, we can initiate that RSV conversation as we see that. We can help, we can provide clear and understandable information. We as scientists can translate that information in a way that our community members can receive it, our patients. We can assess the patient's values, preferences, situation, and then we can reach them. We can explore options and make a decision that aligns with their values and their preferences. And we can say to ourselves and to them, a no today does not mean a no forever. At least now they have the information, and every time they interact with a part of the healthcare system, they can make a decision for themselves. And then we can evaluate, so we can regularly review that decision and its impact on the patient's well-being. Even when someone does get the vaccine, I say, well, aren't you so happy you got that vaccine now? I always check in with them. So when we think about our strategies to encourage vaccine uptake in our minoritized communities, so our more at risk for our communities that can be more at risk for these infections, we can identify those individual factors that contribute to vaccine hesitancy, such as misinformation. Now we have this influx of disinformation right along with misinformation, mistrust, fear, complacency. Sometimes I'll have folks that have never gotten a flu vaccine in their lives, and will be in their 60s and 70s. And now it's like, well, I'm definitely not going to get it if I've gone this long without it, and I feel comfortable in this decision. But it's never too late, and it's never wrong to continue to explore that. Apply principles of active listening. So I actually have adopted this from a colleague of mine, Dr. Rabia Atayi, and she has a yes and approach, meaning that she allows for individuals to discuss, what it is that they may have heard and their feelings, because that matters, right? And as pharmacists, we want to make sure that they're validated, but we can provide that and we can provide factual information of which we know to be true. And we can engage trusted community leaders, to co-create culturally relevant outreach and build vaccine confidence. So I'll get into how it is that I do it a little bit in this next slide, but we want to use those individuals that have that entry point into the community, right? We want to work with them, utilize them, figure out how it is that we can adopt the strategies that they haven't been successful with, and how can we further encourage vaccine access. And then we want to help patients secure affordable access to vaccines. We as pharmacists are aware of those payment options and the fact that Medicare Part B and Part D, are available for that. My students have also really educated me. They have, APHA has Operation Immunization, right? So our team comes out to various clinics, and what they do is they work with drug companies to actually go ahead and get vaccines for individuals that aren't able to be vaccinated. So there are so many different things that we as pharmacists have the skills and capabilities to do to help folks. So what I have is a 3-tiered model that I developed with a community organization that I partner with, Congregations Organized for Prophetic Engagement. And so we have a 3-tiered approach that we developed during COVID-19. And then we said to ourselves, we can see what's coming, so we're going to keep this thing going. So now we continue with other preventable diseases. So our first tier is to engage faith and community leaders. So I work with COPE, and what they do is they work with the pastors within that community. And we actually use that CDC social vulnerability index that Dr. Dang described from that study, and we use that to identify optimal locations for us to go ahead and deploy our intervention. We recruit 4 churches each year to participate in this activity, and we go directly there. And when we're there, we provide education. So that education has various components. I focus a lot on just the pathogenesis of a disease, and I have flu and COVID as a consistent post because we're going through respiratory viral season, right? I would be remiss if I didn't include that. But each year I have a different lead out disease. This past year was RSV. We've done zoster, we've done other diseases, but we really try to capitalize this as a 45-minute education session. And in that education session, I talk to them about co-administration. I talk to them about risk factors. I tell them that, I tell them when they'll be protected from RSV after they get vaccinated, so about 2 weeks or so. So I provide them access to all this information. And after I provide access to all this information and gather insights on community feelings, we do what? We have a clinic where we actually offer these vaccines. So when this clinic where we offer the vaccines, I used to partner with the county of San Bernardino, which is where the community is located. But now I partner with an independent pharmacy because pharmacists get the work done. So with this, we do what's called a warm handoff model. So I talk about co-administration, and then I say, well, go over there to my friends from ABC Pharmacy, an independent pharmacy that's located right in your backyard, and you can go ahead and you can get these vaccines. So I have 2 pharmacists that come out from ABC Pharmacy, and they are the most brilliant women that I have ever met. So as soon as they go in there, Dr. Amy Lay immediately looks up their patient information from our immunization registry. So she says, okay, this is what the patient's eligible for. She passes it to the vaccinating pharmacist, Dr. Sia. The patient sits down, and Dr. Sia says, all right, you eligible for these vaccines. I'm going to give you zoster, I'm going to give you pneumococcal, and I'm going to give you RSV. We're going to do it right here, right now. And guess what? They get it every single time because that's how seamless our system is. We go from education, we go to vaccines. And this past year, we provided over 100 vaccines, and we had some folks get 5 vaccines in one setting. I didn't tell them to do that, but they did. So here we have a model of this. But then I also have my students come with me where they do blood pressure and blood glucose screening. So we try to maximize that opportunity for individuals to have access to many preventative care options while they're there at that clinic. And then these just are our measurable outcomes. So with COVID-19, we had our vaccine clinic that was at Loma Linda University, actually run by Dr. Michael Hogue, who was my first boss. And we went ahead and we had our clinics there. And then after those clinics that we had, we went and had our clinics in the community. And ultimately what we saw was an increased number of those individuals from minoritized communities be vaccinated in our community clinics versus our mass clinic, and that was due to them having access. So we have Sophia, who is our patient. We have this information here. So what is it that we can do to go ahead and ensure that individuals receive these vaccines? Well, we can identify our ideal candidates as we described, right, by going through the medication history, age, and so on. We can educate based on the things that Dr. Dang and myself brought forward, right? We can tell them about the risk and about the disease. And then we can also provide additional protection so we can maximize that vaccine opportunity. So we do have a question here, but I do want to make sure that we get through the Q&A. So I think that I will bypass this question, and then we'll move on to our Q&A section to make sure that we can get through these things. Okay, and these are just our take-home messages. So RSV poses a serious health risk. Vaccine efficacy is high across all those age groups, and we know those adults, right, that are eligible to receive that vaccine. Health equity does remain a critical focus, but community engagement can allow for us to narrow those gaps in vaccine uptake, and clinician engagement and culturally responsive communication are essential. So for our first question that we have, we had an individual ask, how soon after vaccination are patients protected from RSV infection? So as I stated, individuals are protected about 2 weeks or so after they receive that vaccine. I do tell folks, give your body that amount of time to go ahead and build that protection to that vaccine. So, Dr. Dang, I'll let you go ahead and take the
Sure.
next question.
I know. Oh, I know we're a little bit over time. We don't mind staying a few minutes over for Q&A if that's okay with you. I know if you have to leave, that's okay as well. One of the next questions we get is about the RSV being a single dose, and are there investigations for making a possible booster? So yeah, that is something that the manufacturers are continuing to evaluate. The third RSV season and fourth RSV season. So as that data gets published, that will help inform whether or not an additional second dose may be needed. But again, at this time, it is a single dose recommendation.
So we have another question that says, how do you bring vaccine discussions with patients who have said no in the past to ensure you aren't creating a rift in your relationship with them? This is a really great question, and one that it's a place where I navigate often. So what I do is I always revisit, that decision. So I ask open-endedly I started, ask them how they're doing, how they've been doing during this respiratory season. I give them a little bit more insight into the disease, kind of the burden of the disease at this time. So I would have an individual that would come, like I said, each year, and for this time it was the COVID vaccine. So every time I would see them, I would say, oh, you were having a big COVID year. Like, we're seeing disproportionate COVID-19, we're seeing hospitalization, and I would continue to talk to them about that. And then I would ask them, do you have any additional questions about the vaccine? I don't think that that's anything burdensome, and I think that you can really trial that conversation with the person. I don't think it has to be anything forced, but it's never an issue to ask someone if they have continued questions about the vaccine, because you allow for you both to have that open line of communication. And just remember that no does not mean a sustained no forever. And now they know that they have a trusted person that they can continue to access within you.
All right, next question. I'm actually going to combine a few because there's multiple questions about this topic. So if a pregnant person receives a Brisvio at the end of her pregnancy, will she be considered fully vaccinated in her elderly years? Only one time for RSV pregnancy, no future pregnancies, ? And are babies born as a second child when mom had vaccine only in her first pregnancy still protected? So we didn't talk about pregnant patients because our focus was older adults, but I'm happy to answer the question. So the RSV vaccine for maternal vaccination is currently also only a one-time vaccination, so to only one pregnancy. So if mom has a subsequent pregnancy, she is not eligible to receive an RSV vaccine for the second or future child. Instead, those infants will receive long-acting monoclonal antibodies as the intervention. And then the mom does not have future protection against RSV. So the purpose of maternal vaccination is to develop those maternal antibodies, transfer them through the placenta to the infant, so that the newborn is born with protection to sustain them throughout the RSV season, right? So that is not for the mom. She will not have protection in her elderly years. She may need a future vaccine in the future when she is of age. But there's no recommendation for that yet at this time as well.
Yep. Great question. So we also have a question regarding whether patients on peritoneal dialysis should receive the RSV vaccine. So I would say I would consider that to be a high risk, right? So at the point in which you're on dialysis, then that means that you're at end stage, renal disease. So that would be someone that I would consider if they are within that age range that Dr. Dang provided, so that 50 to 74. But of course, that can be a consistent conversation that the provider care team has with that patient.
And then Dr. Jam, maybe I'll ask you this last question before we wrap up. What are the common barriers to RSV vaccine in older adults, and how do these barriers differ between patients and providers and different systems?
Very great question. Hopefully I can answer it in a succinct, robust fashion. So when we think about those common barriers to RSV vaccination in older adults, I think what we discussed is really what you see. So you see those limitations and just the knowledge around the risk factors. So those disease states that Dr. Dang listed, a lot of people don't have a comprehensive list, right, of those disease states and those individuals and they don't identify themselves as the individuals that may be included there. It may be more so that they're thinking about if I have an acute illness, I'm at risk, not if I have chronic morbidities. So that lack of knowledge about the risk factors associated with disease is definitely a limitation. Also, the coverage a lot of times is a limitation. So knowing if the vaccines will be paid for, if you receive it, and then sometimes kind of that lag between individuals leaving Medicaid and then being able to enroll in Medicare, that sometimes can cause gaps in care. So that is something that we do see with older individuals. And something that we also want to consider that may be a limitation for uptake is like the accessibility. So transportation, the places where they can make it to get that vaccine. And just overall, is there a pharmacy like in the vicinity where they can receive the vaccine? Do they have a primary care provider? Many people do not. So that is definitely a significant limitation when we think about it. I think when we think about healthcare providers and health systems, it could also be just the lack of knowledge and gaps in that similar direction. So providers may not be aware of those risk factors for individuals at higher risk for RSV. They also may not be aware of that. Remember, we talked about the change in the age, right? So now it's 50 instead of 60. Providers may not be aware of that. So that may be also a complication. Also, if vaccines are given inpatient, now it's a different conversation when we talk about insurance coverage. So that can sometimes be a limitation to vaccines being given if someone is in an inpatient stay versus, an outpatient receiving therapy and so on. So those are things to consider.
All right, that concludes our Q&A session. Thank you all so much for joining us this morning. We really appreciate your time. And feel free to scan the QR code or visit online to claim your credit and access any activity materials. Thank you all.
Thank you.